It's a pleasure to be with you. This session is titled Community Engagement and Capacity Building, Basic Concepts. There are no disclosures for this presentation. The objectives of this talk include understand basic attributes of successful public health programs, the difference between community engagement and community coercion, the relationship of community engagement to process, development, and external funding, and define community. Everett Rogers defined diffusion of innovation, or the communication of new ideas or approaches, as the process by which innovation is communicated through certain channels over time among the members of a social system. The diffusion of innovation applies to various organized groups and communities. He defined 5 stages in the diffusion of innovation process, including knowledge, where the community is exposed to innovation but lacks sufficient knowledge about the idea; persuasion, where the community is interested and actively seeks out information about the idea to ultimately come to a decision; decision, where the community weighs advantages and disadvantages and decides whether to adopt or reject the idea; implementation, where the community implements the idea to some degree; and confirmation, where the community decides whether or not to continue to use the idea. An effective community engagement process results in facilitation of a community through these 5 stages. A core value of community engagement that must be adhered to is community ownership and control. The community must own their problems and solutions and not just be a participant in the process. This slide lists the characteristics of communities that adopted an innovation or idea, including perceived advantage of the innovation over other strategies and compatibility of the innovation with current norms and beliefs. A brief discussion of the cultural egg diagram seems appropriate. It's adapted from G. Linwood Barney's Layers of Culture. The yellow arrow represents the concept that our behaviors result from deeper cultural and personal influences. At the very center of this cultural egg rests our worldview or deep beliefs. These deep beliefs can be divided into 4 major categories: our beliefs about ourselves as human beings, our beliefs about nature, the supernatural and time, the past, present, and future. These core beliefs then inform our values, the next layer of the cultural egg. These are the things we feel are important. These deep beliefs and values then set the base for the way we do things, our institutions, including how we marry, how we educate our children, how we enforce our laws, how we govern ourselves, how we run our businesses and organizations, etc. Finally, all of those deeper layers emerge as our individual and organizational behaviors. It's easier for an organization and community to apply innovations or ideas that influence the outer layers of the cultural egg, leaving the deep beliefs and values as they are. It's always more difficult to introduce new innovations that challenge a group's deep beliefs and values. That's why the characteristic of compatibility with current norms and beliefs is associated with innovation adoption. Other characteristics of innovation adoption include fully understanding the complexity involved with the adoption of the idea, the ability to test the idea on a trial basis, and the ability to measure or observe implementation results. Measurement is extremely important to determine success and inform improvements as part of a performance management process. There are 4 basic attributes of successful programs for changing risky behaviors, including high-level leadership support, use of best and promising practices, commitment of adequate resources, and community engagement. Leadership support is essential for programs effective in changing risky behaviors. A national program requires support from the president or the president's wife, a state program, the governor, a city program, the mayor, and a business, the chief executive officer. The use of best or at least promising practices is extremely important. Implementing poor ideas results in poor outcomes. Promising practices are often needed in special circumstances to help define best practices. That is particularly true in non-urban rural areas. Many ideas that work in urban settings don't work in rural areas. Adequate resources include people, time, and funding. Community engagement brings an additional set of tools to the health messaging toolkit to change risky behaviors that can, if implemented wisely, improve quality of life and decrease healthcare costs. Communities provide powerful venues to improve the health and well-being of the group in primary, secondary, and tertiary prevention. There is need for greater coordination between public health and its focus on primary prevention and the secondary and tertiary prevention programs of clinical medicine. Public health should take a lead at the national, state, and local level through collaborative processes to foster enhanced integration and coordination of clinical and public health systems and programs. Some basic community engagement concepts are essential for the training of community engagement facilitators, including the 27 topics listed on this slide. Engagement versus coercion, community empowerment, process, not project, relief versus development, external funding, definition of a community, community engagement facilitators and cross-cultural communications, selective primary health care versus comprehensive programs, communications model and transfer of meaning, definition of culture, 7 dimensions of cultural distance, culture shock, social marketing and community engagement, horizontal communication system, 4 levels of message identification, perceived and real needs, bridging, organizations and structures, stages of change, activities and evaluation, LEPSIS, participatory teaching technique, 5 groups of communities, coalition building, community engagement operational structure, overview of a community engagement approach, the Centers for Disease Control and Prevention's 9 community engagement principles, community engagement models, disaster engagement and resilience. These topics provide the basis for a community engagement curricula. So does community engagement actually work? Many community engagement concepts were developed in developing countries lacking public health infrastructures. Communities had to find a way to help improve the health and wellness of their members. The next few slides summarize an international study reported in 2002. From October 2000 to March 2001, Drs. Milton Amayan and Alan Tallons from International Aid in Spring Lake, Michigan, compared 2 community engagement programs, Antique and Surigao del Nor, in the Philippines to 2 control villages. The overall summary of their results indicated community engagement is an effective program for individual and community transformation. Engaged community households are generally healthier and more spiritually focused, and engaged communities are more motivated and self-reliant. This graph demonstrates that families in engaged communities perceived they were healthier due to the program. A majority of community members felt the program made it possible for their barangay to win the Philippine government's Green and Clean Award for community development. Engaged communities had better health parameters versus control communities. They had more antenatal visits. They breastfed their babies more. More children were vaccinated. They used more oral rehydrating solution when their children had diarrhea. They had better nutritional status with higher weight for their children and less malnutrition, including severe malnutrition. The term community engagement is often misused. Much work done in the name of community engagement is actually community coercion, where external experts gather and analyze community data, design a response, apply for a grant, and if funded, try to sell the project to the community. This is not community engagement, but community coercion. Webster defines coercion as the use of physical or moral force to compel to act or assent. Community coercion rarely, if ever, results in community ownership. True community engagement is the facilitation of communities to own their problems and solutions. CDC says that engaging a community is ultimately about facilitating community-driven action. This slide describes the community engagement continuum. Community coercion is located at the left of the slide. This is where things are done to and for people. Community engagement is on the right side. This is where things are done with people. In between, we find consultations, building of partnerships, and coalitions. The closer a program gets to the right side of the chart, the more community ownership and true engagement. The CDC defined community engagement as the process of working collaboratively with and through groups of people affiliated by geographic proximity, special interest, or similar situations to address issues affecting the well-being of those people. In the book Principles of Community Engagement, it further describes the value of community engagement, stating that it's a powerful vehicle for bringing about environmental and behavioral changes that will improve the health of the community and its members. It often involves partnerships and coalitions that help mobilize resources and influence systems, change relationships among partners, and serve as catalysts for changing policies, programs, and practices. Much of the work of community engagement facilitation revolves around developing relationships with community members who are community influencers or decision makers. Hatcher defined 4 constituency development practice elements that are also useful in facilitating community engagement, including know the community, its constituents, and its capabilities, establish positions and strategies that guide interactions with constituents, build and sustain formal and informal networks to maintain relationships, communicate messages, and leverage resources, and mobilize communities or engage and empower communities and constituencies for decision-making and social action. This slide just lists the 3 basic tool sets of health outreach: doing, teaching, and enabling or empowering. Historically, the health profession, including public health, has done a lot of doing and teaching, but not as much enabling. Obviously, teaching can be a helpful tool in the enabling, empowering process. Enabling, empowering is the major goal of community engagement. Public health is the only health profession so strategically positioned to take the lead in community engagement facilitation. Community empowerment is a key element of community engagement and equity for many communities. Empowerment is defined as a group-based participatory developmental process, the community engagement process, through which marginalized or oppressed individuals and groups gain greater control over their lives and environment, acquire valued resources and basic rights, and achieve important life goals and reduced societal marginalization. So empowerment is a proactive process of equalization or equity, often requiring key policy changes and community engagement techniques. So who are the real producers of health? It's not the highly trained health professional, no matter how much they want to be. It's the individual, family, and community that are the true producers of health. Therefore, they need to be empowered and engaged to own their problems and solutions. This is a basic concept behind effective chronic disease management and community engagement. True community engagement is facilitation of a process of problem solving within a community versus the application of a project to a community. It's doing something with, not to a community, as previously mentioned. The community must own the process from the beginning, even determining whether there will be a community engagement process in their community. This is true ownership. Community engagement doesn't fit current grant processes very well with their rigid schedules and guidance. In fact, grants often undermine community ownership. Let's consider the role of community engagement in community development. To do that, we will first discuss the major differences between relief and development. Relief can often be defined as short-term, reliant on outside resources, external ownership of the process, associated with emergency or disaster situations, often creates dependency, and does things to and for people. On the other hand, effective development can be defined as long-term, maximizes local resources, local ownership of the process, associated with a desire to improve the current situation, creates self-sufficiency, and because it is associated with local ownership, local resources, and self-sufficiency, it enables people to own their problems and solutions. As you might expect, true community engagement strives to facilitate communities in effective development. Much development worldwide actually manifests as long-term relief and fails to effectively shift to enable and engage communities for long-term development. The disaster cycle can be divided into 4 phases, including inter-disaster phase, emergency relief phase consisting of early emergency response and late primary care and public health subphases. The emergency and relief phase is followed by the restoration and reconstruction, rehabilitation, and betterment phases. The inter-disaster phase is the time for facilitating community engagement and developing strategic disaster plans. The early portion of the emergency relief phase relates to such things as emergency medical response, trauma care, search and rescue, establishment of emergency communications, relocation of vulnerable individuals, and removal of the dead. The late portion of the emergency relief phase relates to the provision of primary medical care and public health interventions. The public health response of the late portion of the emergency relief phase includes water supplies, disposing of human excreta and solid waste, food safety, shelter, personal hygiene needs, vector control, surveillance activities, and facilitating the community engagement process. Potable water is generally the most important public health response in the late portion of the emergency relief phase. During the Rwanda crisis, over 50,000 people died in refugee camps in Zaire during the first weeks of July 1994 due to cholera. The crude mortality rate reached 28 to 41 per 10,000 per day. The source of the epidemic was contamination of the water sources. The epidemic resolved with appropriate water treatment in the camps. The early and late portions of the emergency relief phases overlap as depicted in this diagram. Ideally, there should be a steady, seamless strategy and transition from the early to late portions of the emergency relief phase. That doesn't always happen, with the early relief phase activities often continuing far too long before transitioning to the late primary care public health response, which includes engaging the community as soon as possible to take ownership after a disaster. External funding, though often necessary, brings with it a threat. External funding comes with a payer agenda that in many instances may fail to support the community's agenda and priorities. It is best to operate within a community's resources if at all possible. Most communities, if appropriately engaged, have adequate resources to significantly impact their perceived needs. If external funding is utilized, it's crucial for the community to remain in charge and control of the agenda to maintain ownership. Maximizing local resources encourages local ownership. This is a quote from the CDC-NIH book, Principles of Community Engagement, 2nd edition, published in 2011. Although it is essential to begin by using existing resources, the literature on capacity building and coalitions stresses that engagement is more likely to be sustained when new resources and capacities are developed. Coalition building is not necessarily community engagement, but can be a part of a comprehensive community engagement process. External funding can move recipients, often coalition organizations, to powerful positions, pushing agendas which may not be in line with the community's agenda. With or without external funding, community ownership of the whole process is extremely important. External funds bring a threat of external control, so be careful when using external funds in community engagement. The term community is not necessarily defined by geopolitical boundaries commonly used in public health. In community engagement, the word community means a group of people who know each other by first name and have a sense of trust, care, and shared responsibility for each other. Generally, people can know a maximum of up to 1,000 to 1,500 people by first name. If a group meets the above definition, then community engagement is often possible. If not, other tools like those of policy, one-on-one clinical counseling, or social marketing may be the only ones applicable. Community engagement is impossible in the absence of community. In summary, an effective community engagement process facilitates a community through the 5 stages of diffusion of innovation. Solutions requiring changes in a community's or culture's beliefs and values are difficult to implement. Much work currently done under the banner of community engagement is actually community coercion. Community engagement is facilitating a process of problem solving versus the application of a project. Community engagement is an essential base for community resilience. The community must be in control of all aspects of a community engagement process.
Take your public health practice skills to the next level. Our specialized certificate courses give you an opportunity to work systematically through a public health topic and demonstrate your understanding of that material in a capstone project. Learn more and sign up at ndphtn.com/certificates.